Hello, good evening guys, welcome back. Now, in yesterday's class, we are discussing about in yesterday's class, we were discussing about endocrine physiology and we have done up till thyroid hormones. We have discussed about growth hormone, we have discussed also about prolactin as well as thyroid hormones. Now, in this class, let's mainly see what are the abnormalities of the thyroid hormone, that is hyperthyroidism as well as hypothyroidism. Actually, these are not the pathology classes, but from my side, I will try to integrate as much as possible. Okay, physio with the pathology. After thyroid hormones, let's discuss about insulin as well as cortisol. Okay, now without any further late, let's continue with the abnormalities of thyroid hormone, that is hyperthyroidism versus hypothyroidism. Hypo versus hyperthyroidism. Guys, it's very simple. See, hyperthyroidism, the thyroid hormones are high in quantity. Okay, the T3 and T4 levels are elevated, and also we have discussed in hyperthyroidism what happened to the value of TSH. The TSH value will always come down in hyperthyroidism. Now, let's go one by one. Let's see the clinical features in hyperthyroidism. What kind of clinical features the patient is going to have? Now, first clinical feature is the patients are going to be slim, okay, or they will become thin. What does I mean by? So, hyperthyroidism, more T3, T4, more basal metabolic rate is there. Now, in the person, the basal metabolic rate is increased. So, more calories are getting broken down. If more calories are getting broken down, hyperthyroidism, if I am getting hyperthyroidism, I will become lean. Okay. Now, the second clinical feature is increase uptake. Increase uptake of food. Okay, increase uptake of food. See, they are taking more and more food. Why? Because their metabolism is increased. So they will consume more and more food till they will lose their weight. Okay, so the food intake is greatly increased, and these patients, their heat intolerant. They are heat intolerant. Guys, this is a very important MCQ which you need to know. Now, in these patients, hyperthyroidism patients, there is more basal metabolic rate, more calories are getting broken down, more ATP is getting broken down, more temperature, they will be having more core body temperature is going to be more. So, if you ask this person to be in a hot environment, do you think he is going to stay there? No, he cannot tolerate the heat. He cannot tolerate the heat and hot environments. So, because already his core body temperature is elevated because of more metabolism. So, these patients are heat intolerant. Now, if you look at their body, there will be a lot of sweat or moistness. Okay, if you look at the palms and soles, they are absolutely sweaty and moist in nature. Okay, now after this, especially if a female, if she is suffering with hyperthyroidism, then she will be having menstrual irregularities. What kind of menstrual irregularities? Like oligomenorrhea. Okay, oligomenorrhea, or even sometimes it can be a menorrhea. Okay, oligomenorrhea or amenorrhea. Why this is very much important is because, see, if a female, if she is suffering with the hypothyroidism, then she will suffer with, okay, she will suffer with menorrhagia, means excessive bleeding. But right now in hyperthyroidism, the female is having oligomenorrhea, okay, or even she can go into amenorrhea. Okay, once she's getting menses once in every 2 months or once in every 3 months. That is oligomenorrhea. Amenorrhea means complete cessation of menses. Okay. Now, apart from that, if you look at the tendon reflexes, now these tendon reflexes are going to be hyper. Okay, there will be hyperreflexia. Okay, there will be hyperreflexia. Now, whenever you try to do the knee jerk or the ankle jerk, Now there will be hyperreflexia. These T3, T4 hormones, more like a sympathetic hormones, they will cause hyperactivation. So there will be hyperreflexia. Now when I am talking about, if I ask you about the heart rate, what happened to the heart rate in a patient who is having hyperthyroidism? Heart rate. In yesterday's class, I have explained to you. Thyroid hormones T3 and T4, especially the T3, the active form, it will act on the myocardium. It makes the myocardium sensitive to catecholamines. When T3 is acting on the myocardium will become more sensitive to catecholamines. So heart rate increases. No doubt, heart rate increases. Here MCQ, which I want you to know is, sir, what is the most reliable sign? Most reliable sign. Okay, most reliable sign of hyperthyroidism. Okay, it is resting tachycardia. Okay, so resting tachycardia or sleeping tachycardia. Okay, even the person is sleeping, normally during sleep, the heart rate should have to go down. But if a patient is suffering with hyperthyroidism, now this patient will have sleeping tachycardia, or even the person is at rest, normally during rest, the heart rate should have to be normal or should have to go down because of the parasympathetic dominance. But here, because of the excessive amount of T3, the patient is having resting tachycardia, and that is the most reliable sign, most reliable sign. Now, after this, you can also have eye signs. What eye signs? Proptosis. Okay, so proptosis or exophthalmos. Okay, proptosis or exophthalmos is going to be seen. What exactly is proptosis? What exactly is proptosis or exophthalmos? Proptosis or exophthalmos means it's a protrusion of the eyeball out of the orbital cavity. Okay, now this patient, whoever is having the hyperthyroidism, especially the severe hyperthyroidism, that is thyrotoxicosis, now those patients will have the protrusion of the eyeball out of the orbital cavity. That is, the proptosis or the exophthalmos can be seen. Now what else can be seen? Normally thyroid hormones are catabolic hormones. Okay, catabolic hormones, and thyroid hormones, they are just like a sympathetic hormones. Sympathetic hormones, they can even excite the central nervous system. Now why I am saying this is, now whenever the patient is suffering with hyperthyroidism, they will have which type of CNS abnormality? These patients will have anxiety. They will have anxiety. Even just by talking with them, you can know this patient is suffering with hyperthyroidism. Why? Because these patients are very much worried about everything. These patients are very much anxious, too much talkative. Okay, so these persons are having anxiety. Not only that, these patients will have pre-tibial mix edema. Okay, so pre-tibial mixed edema. Normally, here students will get confused. Whenever they listen about the word mixed edema or mixed edema coma, they used to think about hypothyroidism. See, mixed edema is not something specific to hypothyroidism, especially if they use the word. Remember, if they use the word pre-tibial mixed edema, think about hyperthyroidism. What exactly is pre-tibial mixed edema? Now we all have tibia bone, right? The shin. Okay, on the leg we are having the tibial part. Now over the tibia there is abnormal deposition of the proteins, that is pre-tibial mixed edema. Pre-tibial mixed edema is seen in hyperthyroidism. Now, first of all, after discussing all the clinical features, now I just want to test your knowledge. Just try to answer yourself. Now, what is the most common cause of hyperthyroidism? What is the most common cause of hyperthyroidism? Hyper. See, the most common cause of hyperthyroidism is Graves' disease. Okay. So, what exactly is Graves' disease? Now, Graves' disease is the autoimmune condition. Okay, let me write it down here. Graves' disease. Now, Graves' disease is autoimmune disorder. Now, what exactly is happening in this Graves' disease? Now, we all know normally think this is the thyroid follicle. Okay, this is the follicular cell. follicular cell. On the follicular cell, which receptors are present? On the follicular cell, TSH receptors are present. Okay. Now, whenever you stimulate these TSH receptors, okay, TSH is coming and it is stimulating its TSH receptor. Now, what happens? In the colloid, whatever T3 and whatever T4 is there, that will be released into the blood. So, upon stimulating the TSH receptors, T3 and T4 are going to get released into the blood. Now, in the condition of Graves' disease, what exactly happens is, see, the person will produce antibodies against the TSH receptor. These antibodies are called as long-acting thyroid stimulating antibodies, which is simply called as LATs, LATS, okay, LATS, long acting thyroid stimulating antibodies. Now, these antibodies, they are just acting like, they are just mimicking TSH. So, they are continuously stimulating the thyroid follicles. So, T3, T4 levels are going to be released more into the blood, causing hyperthyroidism. So, this is what exactly is Graves' disease. Now, regarding Graves' disease, now a few important points which you need to know for your exam. Sir, imagine if I am the person who is having Graves' disease. Do I have goiter or not? Yes, definitely the person is going to have goiter. Why? Because the antibodies are stimulating the TSH receptors continuously. The patient is going to have goiter, enlarged thyroid gland, enlarged thyroid gland. The thyroid gland is getting enlarged. This enlargement is it a nodular enlargement or is it a diffuse enlargement? The thyroid gland is increased in its size. So, we will call it as goiter. Now, is it a multinodular goiter? No. It's not even a nodular goiter. It is a diffuse enlargement, which means entire thyroid gland equally it is increased in its size. So, very important MCQ. There is diffuse enlargement of thyroid gland. Okay, this is the one important MCQ. In which condition you will have diffuse enlargement of thyroid gland? Now, whenever you do biopsy, actually fine needle aspiration is not indicated in Graves' disease. Why? Because there will be hemorrhagic aspirate. Whenever you try to do fine needle aspiration, lot of blood will come. But anyway, this is contraindicated. But whenever if you do it, what kind of histological features you will see? What kind of histological features you will see in a person who is having Graves' disease? The histological picture will be something like this. On microscopic examination, that's the histology. What you will see is scalloping of colloid. Okay, scalloping of colloid is seen in hyperthyroidism. Normally, for example, let me show you. See, let's take it as a colloid. Colloid is a place where T3 and T4 hormones are stored. Now, what exactly is scalloping? Scalloping means at the edges you will have this kind of pattern. Okay, so in the edges you can have the scalloping appearance. So, inside the inside the colloid material, you can have the scalloping in the peripheries. So, this is the histological features what you can see. And what else they can ask you in your exam? What else can you get in your exams is the antibodies are produced in Graves' disease are against. We all know that the antibodies are produced against the TSH receptors, no doubt. But not only TSH receptors, the antibodies are also going and attacking certain other important proteins. What are they? The antibodies which are produced in Graves' disease, they will attack not only the TSH receptor, but also thyroid peroxidase, but also thyroglobulin. Thyroglobulin. So, antibodies are produced against TSH receptor, thyroid peroxidase enzyme, as well as thyroglobulins. Now, after discussing important points about hyperthyroidism, now let's see what are the clinical features which you will see in hypothyroidism. Okay, it's a simple opposite. In hypothyroidism, what happened to T3, T4 levels? T3 levels goes down, T4 level goes down. So, what happened to TSH levels? TSH levels are going to increase. Now, before discussing the clinical features, now what is the most common cause of hypothyroidism? The most common cause of hypothyroidism in world, if someone asks you, in world it is iodine deficiency. What is the most common cause of hypothyroidism in India? Okay, in India again it is iodine deficiency. But what is the most common cause of iodine deficiency in Western, okay, Western world or Western countries? It is Hashimoto's thyroiditis. Okay, now what exactly is Hashimoto's thyroiditis? This is a very important MCQ which you need to know. Here itself, before discussing clinical features, now itself let me tell you, I have already explained to you what exactly is Graves' disease. Graves' disease is an autoimmune disorder where the thyroid gland, the thyroid follicles are excessively stimulated. So the person is having hyperthyroidism. Remember, Graves is an example of hyperthyroidism. But what exactly is Hashimoto's thyroiditis? Remember guys, usually, okay, just in a convention, we will say something like this. See, whenever you listen about the word thyroiditis, okay, there are different types of thyroiditis. Hashimoto's thyroiditis, the Riedel's thyroiditis, the Dickver's thyroiditis, acute bacterial thyroiditis, different types of thyroiditis are there. All these thyroiditis at the end of the day, they will cause hypothyroidism but not the hyperthyroidism. Graves' disease is an example of hyperthyroidism. All the thyroiditis conditions will eventually cause hypothyroidism. Hypo. Now, right now, what I am discussing, which type of thyroiditis? I am discussing about Hashimoto's thyroiditis. Now, what exactly is happening in Hashimoto's thyroiditis? Again, same etiology, sir. The etiology is here. Again, it's the autoimmune disorder. Okay, it's autoimmune disorder. What is happening? Antibodies are produced against, see, the antibodies are produced against TSH receptors again and thyroid peroxidase and even thyroglobulin. Now these antibodies, don't confuse with the Graves' disease. They are stimulatory antibodies, long-acting thyroid stimulating antibodies. But here these antibodies are destructive antibodies. They will come and they will attack the thyroid gland. They will cause the destruction of the thyroid follicles. They will damage the thyroid follicles. So what is happening? Inflammation. So thyroiditis. The antibodies are causing inflammation. Okay. So that inflammation is causing decreased T3 and decreased T4. But important point which I want you to know is, so during acute phase or in the initial phase, what does it mean by initial phase? Initially, the antibodies are coming and attacking the thyroid gland. Now, in the thyroid gland, already T3, T4 is there initially. Now, these antibodies are attacking the thyroid gland, so thyroid follicles are getting damaged. Colloid is getting now leaked into the blood. So, initially, in Hashimoto's thyroiditis or any other type of thyroiditis, there is initial phase of hyperthyroidism. So, in acute phase, what happens? There is hyper. Okay, in initial phase, there is hyperthyroidism. But later on, eventually what will happen? Eventually, the gland is going to be so much inflamed, the gland is not going to produce any T3, T4 further. So, initially there is hyperthyroidism because of the leakage of the T3, T4 from the colloid which is already formed. Okay, initially hyperthyroidism, later the patients will go into hypothyroidism. But important is this thing. Okay, Hashimoto's thyroiditis cause hypothyroidism. It's the most common cause of hypothyroidism in the Western world. Now, after discussing about the causes, now let's see what are the clinical features. Hyperthyroidism, let's see, exact opposite. Hyperthyroidism, the patient is going to be slim and thin. In hypothyroidism, the patient is going to be obese. First clinical feature, the patients are going to be, okay, the patients are going to be obese. Now, in hyperthyroidism, the patients will take more and more food. Here, the metabolism is very, very less. There is no T3 and T4. The metabolism is very less. So, these patients, they decrease the food intake. Okay, they decrease the food intake. And hyperthyroid patients, they are heat intolerant. Here, there is no metabolism. There is no ATP breakdown. There is no calories are getting broken down. The basal metabolic rate is going down. So, thermogenesis also goes down. So, these patients with hypothyroidism, they are cold intolerant. Okay, they cannot sit in a room where there is AC. So, these patients are cold intolerant. Okay, cold intolerant. And these patients will have dry scaly skin. Okay, dry scaly skin. Now, what do the hyperthyroid patients will have? The hyperthyroid patients have sweaty, moist skin. Okay, all the time the skin is going to be moist. Palms and soles are going to be absolutely moist, sweaty. Here the patients are having dry scaly skin. Now the females who are suffering with hypothyroidism, I have already explained to you, they are suffering with menorrhagia. Okay, they will suffer with menorrhagia, that is excessive bleeding. Menorrhagia means too much amount of bleeding during menses. Now what about the tendon reflexes? There will be hyporeflexia, hyporeflexia, and important point, see, sir, if I am talking about the heart rate, okay, in hyperthyroidism, what about the heart rate? The resting, there is resting tachycardia or sleeping tachycardia is seen. Okay, sleeping tachycardia, resting tachycardia. Here, there is no T3, T4. The heart rate automatically comes down. There is bradycardia. Okay, so there is bradycardia. But important MCQ here, what I want you to know is, what about the reflexes? The reflexes are going to be hyporeflexia. Okay, now the most reliable sign, okay, most reliable sign. Okay, the most reliable sign is hung up ankle jerk. So the hung up ankle jerk, okay, whenever you try to do the ankle jerk, yes, it will happen, but ankle will come back slowly. Ankles. So hung up ankle jerk is the most reliable sign in a hypothyroidism. In hyperthyroidism, the most reliable sign is tachycardia. Okay, so here I have discussed the abnormalities, that's both hyperthyroidism as well as hypothyroidism and their clinical features. Now after discussing them, let's discuss about something called as a congenital hypothyroidism. Congenital hypothyroidism. Now if a person is having, okay, imagine that there is this one baby who is having congenital hypothyroidism. By birth itself, the T3, T4 hormones are not enough, they are deficient. Now this person is going to suffer with a condition called as, anyone knows? Guys, let me check the chart. Guys, just tell me what happened to the patient who is having no thyroid hormones from birth. These patients are going to suffer with a condition called as, anyone knows? There is this one condition. The name of the condition is cretinism. Okay, yes, excellent. Iman, you're true. It is cretinism. Now, this patient who is suffering with the cretinism, definitely they are going to have certain clinical features. What are the clinical features? I have explained to you the thyroid hormones, catabolic hormones during the childhood. The thyroid hormones are very much important for the development of bones, for the growth. So whenever there is hypothyroidism, the patient will be dwarf. The patient is going to be dwarf or decreased growth will be there. Apart from that, this patient will be having mental retardation. Okay, so cretin patients, okay, cretinism, which is an example of congenital hypothyroidism, the patients are going to be mentally retarded, as well as the patients are going to be having less height, dwarf. Okay, now here one more clinical link which I want to discuss. So whenever we discuss about the hypothyroidism, now just tell me, sir, during hypothyroidism what happens? T3, T4 levels, T3 decreases, T4 decreases. We know T4 is the one which gives the negative feedback. Whenever T4 decreases, what happened to TSH? TSH level increases. Okay, T4 and TSH, they are exactly opposite to each other. Okay, they are inversely relational. Whenever T4 is going down, TSH will go up, or just take an opposite thing. So whenever T4 increases, what happened to TSH? It will come down. But there is one condition, sir. There is one condition where both T4 and TSH levels both are elevated. Now there is a condition where T4 levels are elevated, TSH levels are elevated. Now, can you name me what is that syndrome? What is the clinical condition where T4 levels are elevated at the same time TSH levels are elevated? Do you know, guys? Anyone? The condition where the T4 levels are elevated as well as the TSH levels are elevated. I'm checking. Okay, I think you don't know about it, but let me write it down here. That's name of the syndrome is called as Reffi-Toff syndrome. Okay, the name of the syndrome is called as the Reffi-Toff syndrome. Now, what exactly is happening in this Reffi-Toff syndrome is that T4 receptors are resistant. Okay, there is a T4 resistant. The T4 receptors are resistant. T4 receptors. So the T4 is unable to give the negative feedback. T4 is there, but is unable to give the negative feedback. The T4 cannot stimulate the receptors. Why? Because T4 receptors are mutated. So T4 is unable to give the negative feedback. Okay, so simply TSH is also getting released. No negative feedback. So both T4 and TSH are elevated. This syndrome is called as Refitoff syndrome. Now, after discussing about Refitoff syndrome, let's also discuss about some important anti-thyroid medications. Okay, which you need to know for your exam purpose. Okay, anti-thyroid drugs. Now, we know the entire process of making thyroid hormones. Okay, so first iodine uptake, second one oxidation, organification, coupling reaction. Now the T4 need to be converted into T3, that is peripheral conversion with the help of 5' deiodinase. We have seen all these important steps. Now, if you can inhibit those steps, you can decrease the T3, T4 hormone production. You can treat hyperthyroidism. So anti-thyroid drugs, the first group includes sodium iodide symport inhibitors. Okay, so sodium iodide symport inhibitors. Now, if you can inhibit the uptake of iodine into the follicular cells, if you can inhibit the iodine trapping into the follicular cells, automatically T3, T4 hormone production will go down. Now, can you try to recall the name of drugs which are inhibiting sodium iodine symport? Can you name those drugs? Can anyone name those drugs which inhibits the uptake of iodine? The name of the drugs include thiocyanate and perchlorate. So if you use the drugs like thiocyanate and perchlorate, these drugs will inhibit the uptake of thyroid hormones. They will inhibit the uptake of iodine. Now the second group of drugs which I am going to discuss are TPO inhibitors. A very important enzyme, the thyroid peroxidase. If thyroid peroxidase is inhibited, definitely there is no oxidation, organification or coupling reaction. So automatically T3, T4 hormone levels will go down. So the examples of the TPO inhibitors are carbimazole, methimazole and PTU, propyl thiouracil. So carbimazole, methimazole, propyl thiouracil, all of these are thyroid peroxidase enzyme inhibitors. Now the third group of drugs which you can use are peripheral conversion inhibitors. Peripheral conversion inhibitors. Now, what exactly is peripheral conversion? We all know T4 is going to convert it into T3 with the help of 5' deiodinase at the level of tissues. Now, if you can inhibit this step, automatically T3 levels will come down. So, automatically hyperthyroidism is treated. Now, can you name me those drugs? Anyone? Guys, anyone from the chat? Okay, can you name one example of like this peripheral conversion inhibitor? I can give you a small clue. The drug's name start with P. The propranolol, guys. Okay, beta blocker. Propranolol, which is a beta blocker. Okay, it's a beta blocker, and again propyl thiouracil. Okay, so propranolol and propyl thiouracil, these drugs, they will inhibit peripheral conversion. Now see, propyl thiouracil, it's acting in both ways. Propyl thiouracil, it inhibits the thyroid peroxidase as well as it inhibits the peripheral conversion. It acts in both ways, no doubt. Now one more important point about the propyl thiouracil is, so propyl thiouracil is considered as a drug of choice for hyperthyroidism in pregnancy. Okay, so during pregnancy, if a mother is suffering with hyperthyroidism, then the drug of choice is propyl thiouracil. Now, what is the mechanism of action of propyl thiouracil? P for peripheral conversion inhibitor, P for thyroid peroxidase inhibitor. Okay, thyroid peroxidase is getting inhibited as well as peripheral conversion is getting inhibited. Now, we are done with the thyroid hormones and its abnormalities, that is hyperthyroidism as well as hypothyroidism. Now let's start with the other endocrine gland, which is pancreas. Okay, pancreas. Now what are the two important functions of pancreas? There is exocrine function, as well as there is endocrine function. So pancreas is having both exocrine function as well as endocrine function. What exactly is exocrine function? Exocrine function is production of digestive enzymes. So pancreatic lipases, carboxypeptidase, procarboxypeptidase, trypsinogen, chymotrypsinogen, all these are coming from pancreas. Okay, pancreatic amylase, colipase, all these are the digestive enzymes which are coming from the pancreas. So pancreas helps in digestion, no doubt. But pancreas is also having one more important function, that is the endocrine function. Now what exactly is endocrine function? It helps in production of hormones. Okay, so right now we are more concerned about the endocrine function. Now let's talk about the important cells which are present in the pancreas. Cells in pancreas. Now what are the important cells which are present in the pancreas? Especially I am talking about the endocrine functions. The first cell is alpha cell, second cell is beta cell, third type of cells are called as T cells and F cells. Now let's see what is the important function of alpha cell. Every student, okay guys, yeah, so every student knows that alpha cells are helping in the production of glucagon. Which hormone? Glucagon, sir. Beta cell helping in the production of insulin, and D cells helps in the production of what? Somatostatin. So just don't forget, somatostatin is coming from where? Somatostatin is coming from the D cells of pancreas. True statement. Somatostatin is also coming from the hypothalamus, growth hormone inhibiting hormone. Somatostatin is also coming from the hypothalamus, no doubt. And the same somatostatin, when we are discussing about the GI tract, somatostatin is also released from the D cells in the gastric gland. See, the D cells are also present in the gastric glands. Now those gastric glands, those D cells will also produce somatostatin. Now what is the function of somatostatin? Wherever you listen about the word somatostatin, it inhibits everything. So somatostatin from the hypothalamus inhibits growth hormone. Somatostatin from the D cells inhibits insulin release as well as the glucagon release. And somatostatin from the D cells of gastric glands, they will inhibit the release of gastric acid. Okay guys, do you have any doubts? Shall I go further? Shall I continue? Okay, shall I continue? Now let me just give me 1 minute. Yeah, so alpha cell is helping in the production of glucagon, beta cell is helping in the production of insulin, and delta cells helping in the production of somatostatin, and F cells are producing something called as pancreatic polypeptide. Okay, now let's see what are the important functions. So whenever you see about the word glucagon, what should come to your mind? What is the important function of this glucagon? Glucagon increases the blood glucose levels. Glucagon, it increases the blood glucose levels. Okay, now the insulin, what it will do? Insulin, whenever you see the word insulin decreases the blood glucose levels, no doubt. Insulin decreases the blood glucose levels. Now what this somatostatin will do? Somatostatin, it decreases both insulin release and decreases both glucagon. Okay, so both insulin and glucagon release are going to be decreased with the help of somatostatin. Now here what I want you to know is, sir, beta cell, most of the students only know this thing. Beta cells are helping in the production of insulin, no doubt. Insulin decreases the blood glucose levels. But beta cells not only produce insulin, beta cells also produce some other hormones. Now what are they? Beta cells will produce something called as amylin, and beta cells also produce something called as a C-peptide. A lot of times examiner can try to just check your knowledge about this C-peptide. What exactly is this C-peptide? Okay, so C-peptide is released in equimolar concentration along with insulin. Okay, C-peptide is released in equimolar concentration along with insulin. For example, if endogenously 100 insulin molecules are produced, it means along with the 100 insulin molecules, 100 C-peptide molecules are produced. So they are produced in equimolar concentration. And what happens to the C-peptide? The C-peptide is going to be excreted out in urine. Okay, so by checking the urinary, remember, by checking the urinary C-peptide levels, you can estimate the amount of endogenous insulin produced. Okay, just by looking at the amount of C-peptide in the urine, you can get to an idea how much amount of insulin is produced inside the body. So the C-peptide is endogenous marker. Okay, endogenous marker for insulin. Okay, it's endogenous marker for insulin production. Okay, I should say something like this. Okay, not endogenous marker, it's a marker. Okay, it's a marker for endogenous insulin production. Okay, it's a marker for, okay, let me write it down again here. It's a marker for endogenous insulin production. Insulin production. Okay, now, so we have discussed about alpha cells, beta cells, D cells and pancreatic cells. Okay, F cells, which is producing the pancreatic polypeptide. Now let's start about insulin. Okay, insulin, the most important hormone in the entire endocrinology, that's the insulin. Now insulin, first point, is it an anabolic hormone or catabolic hormone? No doubt, insulin and growth hormones are anabolic hormones. Okay, they are anabolic hormones, and this insulin was discovered by scientists called as Banting and MacLeod. Okay, so Banting and MacLeod are the scientists who have discovered the insulin, and the structure of insulin was given by Sanger. Okay, who is this Sanger? Sanger given the structure. The structure of the insulin was described by Sanger. Now, what exactly is the structure? Insulin is made up of, okay, insulin is made up of two chains. Okay, alpha chain as well as beta chain. Okay, two chains will be there. This is alpha chain and this is the beta chain. Alpha as well as the beta. Now, alpha chain is a small chain. Why? Because it's having less number of amino acids. How many number of amino acids will be there in alpha chain? There is 21 amino acids. Okay, there are 21 amino acids present in the alpha chain, and in the beta chain there are 30 amino acids present. So in total, insulin molecule is made up of how many amino acids? In total, insulin molecule is made up of out of 51 amino acids. Okay, 51 amino acids are there in the insulin molecule. Now, apart from that, in the exam they will ask you, what is the T half of insulin? What is the half-life of insulin? Now, insulin is going to be there in your blood active for 4 to 6 minutes. Okay, 4 to 6 minutes is the T half of insulin. Now, what insulin will do? We know it. Insulin will decrease the blood levels of glucose. How it will decrease the blood levels of glucose, we'll discuss. But before that, I want you to know, normally, sir, let me show you here. This is one beta cell. Okay, this is one beta cell of pancreas. This is beta cell which is there inside the pancreas. Now, I have already explained to you the beta cells have produced the insulin. Now, insulin molecules are present inside the C. This is the vesicle inside which there is insulin. Okay, insulin is there. Normally, this insulin is kept along with which ions? The insulin is kept along with zinc ions. Okay, the insulin molecules are kept along with zinc ions. Okay, this is the first MCQ. Insulin, okay, kept along with zinc ions. Why zinc ions? Why? Because this zinc increases the stability. Okay, the zinc increases the stability in the structure of insulin molecule. Okay, zinc. Now here I just want to correlate with the pathology. How good you are? Let me see. If the patient is suffering with zinc deficiency, okay, for example, imagine that I am a patient. Okay, I am a patient who is having zinc deficiency. Now, which kind of what disease I will what is the disease that's going to manifest inside my body? Which disease? Zinc deficiency will cause iron deficiency will cause anemia. Okay, in the same way, zinc deficiency will cause anyone. Anyone guys? Zinc deficiency will cause which disease? I'm checking. Pawan Kumar, Huria, Kami. Come on guys. Zinc deficiency will cause which disease? Deficiency of zinc will cause a disease. Lot of times this question was asked. Even the recent exams, this question was asked. Deficiency of zinc will cause diabetes. No. I'm asking about a disease, especially because of the zinc deficiency. It is called as acrodermatitis. Acrodermatitis enteropathica. These are the direct single liner questions which you should never ever miss. Deficiency of zinc will cause acrodermatitis enteropathica. Can you tell me copper deficiency causes which disease? Copper deficiency. If you are having deficiency of copper, the copper deficiency will cause which disease? Copper deficiency. And copper excess. If copper is excess in your body, okay, excess, that will cause a disease. Okay, here there is no relationship between copper and the current right now our topic. We just discuss about the zinc, right? A lot of time question was asked, zinc deficiency will cause a disease called as acrodermatitis enteropathica. In the same way, copper deficiency will cause anyone's? See, someone is saying Wilson disease. No, Wilson's is not because of deficiency. Wilson's is because of copper excess. So, Wilson's disease is because of copper excess. Now, copper deficiency will cause Menkes disease. Okay, which is called the Menke-Kinke disease. Okay, simply Menkes disease you can say. Menkes disease. Menkes disease is because of copper deficiency. Copper excess will cause Wilson's disease. Okay. Now, after this, let's now talk about the insulin release. How insulin is released. Okay, how insulin molecules is going to be released. Okay, normally when do you need insulin? Just tell me guys, when do you need insulin? See, you need insulin whenever your blood glucose levels are elevated. Whenever your blood glucose levels are elevated, you need to have insulin. For example, let me show you here. One cell, that is the beta cells of islets of pancreas. This is the beta cell. Okay. Now, here is your blood vessel. This is your blood vessel. Okay, let me show you. Here is your blood vessel. Now, you had food. Okay, now you had food. Now, whenever you eat food, now what happens? Food is going to digest, sir. Food is getting digested. Whenever food is getting digested, what happened to the glucose levels? The blood glucose levels are going to be elevated. See, now your blood glucose levels are elevated. Now, whenever blood glucose levels are elevated, now do you want glucose in the blood or do you want the glucose to be in the tissues? You want the glucose to go into the tissues. So, how glucose go into the tissues, sir? With the help of insulin. Now, first of all, the first thing, how our beta cell will know that there is increased blood glucose level. How this beta cell, it already, see, just one point, see, already this beta cell is having vesicle. Inside the beta cell, insulin molecules are already stored. Already insulin is produced. Okay, now this insulin should have to come into the blood. How this beta cell will know that the blood glucose levels are elevated? How means, see, first event is this glucose is going to enter into the beta cells. On the surface of beta cells, there are transporters called as GLUT type 2, GLUT type 2, glucose transporter type 2. Repeatedly tested MCQ. So, GLUT type 2 molecules are present on beta cells of pancreas. Now, glucose is going to enter into the cell. Now, here is our glucose. Now, what does this glucose do? Now, this glucose will enter into glycolysis. Okay, glycolysis. Now, just stop here. Okay, just stop here. I just want to discuss a few more important points about this beta cell. Normally, these beta cells, they already have insulin here. They already have insulin inside the vesicles. But why insulin is not getting released is because, see, on the surface of these beta cells, let me show you with a different color. On the surface of these beta cells, there are certain channels present. What is the name of this channel? Sir, these channels, now just tell me with the function. So, these channels are all the time letting potassium to go out of the cell. So, potassium is all the time leaking out of the cell. Now, whenever the potassium is leaking out of the cell, what happened to intracellular potentials? Intracellular potentials will be definitely negative. Why? Because the positive charges are going out. So, what happened to the resting membrane potential? The resting membrane potential is going to be very, very less, negative. Okay. Now, see, sir. Now, what happens? Now, whenever the person had food, this glucose will enter into the cell. The glucose will be the glucose will enter into the glycolysis. Now from the glycolysis, after glycolysis, there is Krebs cycle. Okay, Krebs cycle is going to happen. After Krebs cycle, electron transport chain is going to happen. You all know these biochemical things, biochemical pathways. Okay, now at the end, sir, at the end, after electron transport chain, we have ATP inside the cell. ATP molecules, the power molecules, the currency of the cell. Okay, the energy for the cell. ATP is there. Now, what does this ATP will do? Now, these ATP molecules, they will come and inhibit these channels. See, I'm just showing the ATP with the star. Okay, ATP with the star. Now, these stars, these ATP molecules are coming and inhibiting the potassium channels. So we can say these potassium channels are sensitive to what? These potassium channels are sensitive to ATP. So these potassium channels are called as ATP sensitive potassium channels. Okay, they are called as the ATP sensitive potassium channels. Now what is happening? Sir, potassium is now getting accumulated inside the cell. Potassium is not going out. Potassium is getting accumulated within the cell. Now the positive charges are building within the cell. Now what will happen? Now cell will undergo depolarization. Now what happens is on the cells, on the beta cells, now which channels are going to open? Now calcium channels are going to open, sir. Okay, now calcium will starts to come into the cell. Okay, before no calcium is coming, calcium channels are there, but they are closed. But whenever the cell is depolarized, calcium influx happens into the cell. Now this calcium will come and bind to the vesicle. We all know calcium is going to help the contractile proteins to contract. So now these vesicles, with the help of calcium, they will start to move within the cell. Now this calcium, now these vesicles, what they will do? Now please see here. Now just I am erasing all of these things for the convenience. Okay, now this vesicle, it will start to move. So the vesicle is going to come here and it is going to fuse with the membrane. So what happens is this membrane is going to fuse and it releases the insulin molecules into the blood. So insulin ultimately comes into the blood. Okay, insulin ultimately comes into the blood. Now this is how insulin is released. So insulin is released with the help of which channels? Mainly it's a ATP sensitive potassium channels. Okay. Now after discussing this, now here I just want to discuss what exactly happens later. Okay, what exactly happens later? See, now let me show you. Here is a blood vessel. Now in the blood vessel, who is there? Sir, in the blood vessel there is glucose. Okay, in the blood vessel there is glucose. Now whenever you have increased glucose, I have already explained to you, insulin came into the blood, sir. Here is insulin now in the blood. Insulin is there in the blood, glucose is there in the blood. We all know that insulin have to decrease the blood glucose levels. How it will decrease the blood glucose levels, sir? Now here I am showing you a muscle. Okay, here I am showing you a muscle. Okay, a skeletal muscle especially. Or you can also take adipocyte here. Now this insulin, it will come and act on the muscle. Now there is a receptor here on the muscle, which is a tyrosine kinase receptor. Whenever insulin molecule comes and stimulate the tyrosine kinase receptor, okay, whenever insulin molecules comes and stimulate the tyrosine kinase receptor, now for the first time, now only what happens is these skeletal muscles, now they will plant, okay, now they will plant channels. Okay, what are these channels? Now these channels will allow the movement of glucose. These channels will allow the movement of glucose from the blood into the tissues. So before this, like whenever there is no insulin, there are no channels. But whenever there is insulin, these channels are produced. What these channels are doing? These channels are allowing the glucose to enter into the skeletal muscle. Now, can you name me what are these channels? These are again glucose transporters. Which type of glucose transporters? These are GLUT type 4. So the GLUT transporters, glucose transporter type 4 are present on the skeletal muscles as well as on the adipocytes. Okay, so by incorporating glucose transporters type 4, insulin is helping to decrease the blood glucose levels. Okay guys, is it clear? Is it clear? If you have any doubts, you just put it in the chat box. Everything seems good. If you have any doubts, you just put it in the chat box, guys. Now, the question which I want you to know is for your exams especially, normally tissues can uptake the glucose only with the help of insulin or not. So whenever there is insulin, that insulin helps in, okay, that insulin helps in glucose uptake. Okay, that insulin helps in glucose uptake with the help of which transporter? GLUT, GLUT type 4. Now, MCQ. There are certain tissues in your body. Okay, there are certain tissues in your body which will uptake glucose without insulin. Okay, even without insulin, these tissues will uptake the glucose. Can you name me those tissues? So, there are certain tissues which does not require insulin, which does not require glucose transporter type 4 for the uptake of glucose. Now, which tissues? Mainly, sir, central nervous system. Okay, the central nervous system doesn't require insulin. Insulin is not needed, as well as your RBCs. Okay, RBCs. Now, they doesn't require glucose transporter type 4. But these tissues, the central nervous system and RBCs, they all the time have a specific type of glucose transporters called as GLUT1. Okay, GLUT1 or glucose transporter type 1. So this glucose transporter type 1 helps in uptake of basal glucose at all the times, even whenever there is no insulin. So even whenever there is no insulin, these tissues all the time they will help in uptake of, these transporters will help in uptake of glucose. Okay. Now, after discussing this, let's talk about something called as sulfonylureas. Okay, let me write it down here. Sulfonylureas. Now, what exactly is sulfonylureas and what is the mechanism of sulfonylureas? The sulfonylureas are anti-diabetic drugs. They are anti-diabetic drugs. Can you tell me what is the mechanism of action of sulfonylureas? How the sulfonylureas are working? What is the mechanism of action of the sulfonylurea? It's an anti-diabetic drug. So if it's an anti-diabetic drug, definitely it have to decrease blood glucose levels. How the sulfonylureas are working, sir? Now, the examples of sulfonylureas. First of all, let me write it down here. The examples of sulfonylureas. Can anyone tell me? Tolbutamide, glyclazide, and chlorpropamide. Okay, so tolbutamide, glyclazide, chlorpropamide, all these drugs are examples of sulfonylureas. Apart from that, other drugs are also there, which includes glipizide, glyburide. Okay, all of these are sulfonylureas, which are anti-diabetic drugs. Now, what is the mechanism of action of these drugs? How they are going to treat the diabetes mellitus? See, the mechanism of action is all of these drugs will go and inhibit ATP sensitive potassium channels. Okay, all of them, they will inhibit ATP sensitive potassium channels. From here we know the story. Sir, whenever you inhibit the ATP sensitive potassium channels, potassium is going to stay within the cell. Now this potassium accumulation will cause the depolarization of the beta cell. Whenever the beta cell is depolarized, calcium influx will happen into the cell. This calcium will bind to the vesicles, will move the insulin vesicle towards the membrane. So the vesicle will fuse with the membrane and releases the insulin. So insulin, what it will do? It will decrease the blood glucose levels by incorporating glucose transporters type 4 on skeletal muscles as well as adipose tissues. Okay, so the mechanism of action of sulfonylureas is inhibits the ATP sensitive potassium channels. Okay, ATP sensitive potassium channels. Here, one more important pharmacology I want you to know is the diazoxide drug called as diazoxide. Now, what exactly is this diazoxide? Anyone knows from the ones who are watching this lecture? Now, any one of you know what exactly is diazoxide and what is the mechanism of action of diazoxide? And diazoxide is used in which conditions? Anyone? I'm just checking the chart. Anyone? Come on. Kami, Benedict, Dopamine Med School, Pawan Kumar. Do you guys know what exactly is diazoxide? The mechanism of action of diazoxide? So diazoxide, it's the exactly opposite thing. Sulfonylureas, they are closing the potassium channels. They are closing the ATP sensitive potassium channels. But diazoxide is potassium channel opener. Okay, it's a potassium channel opener. Which potassium channels? ATP sensitive potassium channels. Now the ATP sensitive potassium channels are opened. When the ATP sensitive potassium channels are opened, what happened to the beta cells? Beta cells are hyperpolarized. Okay, they are hyperpolarized, that they are inactivated. They are absolutely inactivated. Now, in which conditions you have to use it? So this diazoxide is used in the treatment of condition called as insulinoma. Insulinoma. What exactly is insulinoma? So here is the pancreas. See, here is the pancreas, and inside the pancreas there is a tumor. Okay, this tumor is insulinoma. What it is doing? It's continuously releasing insulin molecules. It's continuously releasing insulin. Is it good or bad? Definitely bad. This insulin will cause hypoglycemia and the patient can go into coma. Okay, so what we have to do? We have to decrease the insulin production. How we can decrease the insulin production? By inactivating the beta cells. How we can inactivate the beta cells? See, if you use the drug like diazoxide, what happens is the potassium channels are going to open, the beta cells will become hyperpolarized. So automatically what happens? Insulin release is going to be decreased. So automatically insulin levels comes down. This is the mechanism of action of diazoxide. Okay. Now, apart from that, what else you should know regarding insulin? Other actions of insulin. Okay, other actions of insulin. Guys, we are discussing insulin along with the insulin, what it is exactly doing with the glucose. Now, my question right now for you is, how insulin is going to alter the electrolytes? Which electrolyte abnormalities are going to be seen with the insulin release? For example, right now, imagine that there was this one patient who is having diabetes mellitus. He came to me and I gave him insulin shot, insulin injection. Now tell me, which electrolyte abnormalities are going to be noted? Anyone? Which electrolyte abnormalities? Don't know? So remember, it's a potassium. Answer is potassium. Okay, it's a potassium. Excellent, Abid Nasir. It's a potassium. Now, what exactly insulin will do to the potassium is, see, now this is your cell, sir. Okay, imagine this is your cell. Now, on the surface of cell, who is there? Sodium, potassium, ATPases are there. Okay, sodium, potassium, ATPases. Okay, what the sodium, potassium, ATPases are doing? Sodium, potassium, ATPases throws the sodium out of the cell. 3 sodium will go out and brings the 2 potassium into the cell. Now, what our insulin will do is, insulin will come and activate the sodium, potassium, ATPase. So, lots and lots of potassium from outside will start to enter into the cell. From outside, now potassium will enter into the cell. So, whenever you give insulin, that insulin will cause hypokalemia. Okay, so hypokalemia is going to be seen. So remember, what insulin does to potassium? Insulin will take all the potassium from out of the cell and will push the potassium into the cell. Okay, and will pack the cells with the potassium. So insulin can be used in which conditions? Insulin is used in the treatment of hyperkalemia, sir. Okay, insulin is used in the treatment of, let me write it down here, the treatment of hyperkalemias. Okay, used in the treatment of hyperkalemia. So because the patient is suffering with hyperkalemia, more potassium is there. Now this potassium can trigger the arrhythmias and can kill the patient. So what we can do is, you can treat the hyperkalemias by giving the insulin. Whenever you give the insulin, all the potassium will go into the cell. Okay, now let's see a few more important actions of insulin. Insulin decreases the blood glucose. Okay, decreases blood glucose. No doubt. By sir, insulin will incorporate glucose transporters type 4. So glucose is going to enter into the skeletal muscles, no doubt. But in your exams, they will test you. Insulin will inhibit glycogenolysis, gluconeogenesis, glycogen synthesis. So you should know what and all the biochemical reactions which are inhibited because of insulin, and what and all the biochemical reactions which are stimulated by insulin. Okay, first see insulin. Let me write it down here. Insulin, what it will do? First, insulin is going to stimulate glycogenesis. Now, what exactly is happening in glycogenesis? In glycogenesis, all the glucose is taken up by the liver and it's getting converted into glycogen. Okay, glycogenesis or glycogen synthesis. So glucose levels are decreasing in the blood or not? Yes, glucose levels are decreasing. So glycogenesis is stimulated. Okay, glycogenesis is stimulated. And lipogenesis. Whenever you have enough amount of glucose, the glucose is converted into fats. Lipogenesis. So blood glucose levels will come down. And insulin will also stimulate glycolysis. So in glycolysis, what is happening? Normal body tissues, your skeletal muscles, your adipose tissues, your body cells are going to uptake the glucose, helps in production of ATP. So what is happening to blood glucose levels? From the blood, glucose is getting transferred into skeletal muscles and adipocytes. So what insulin is doing? Our insulin, this fellow is doing activation of glycogenesis, activation of lipogenesis, and activation of glycolysis. Okay, glycolysis. And the same insulin molecules will inhibit certain reactions. Which reactions? Those reactions which will increase the blood glucose levels. Those reactions, concentrate on my words. Those reactions which will increase the blood glucose levels, all those reactions will be inhibited. Why? Because insulin have to decrease the blood glucose levels. So what are those reactions? Now let it take it down here. Which reactions are inhibited? First one is glycogenolysis. Whenever there is glycogenolysis, blood glucose levels are elevated. So this glycogenolysis is inhibited. The second thing, gluconeogenesis. Gluconeogenesis is also inhibited. Third one, lipolysis. Lipolysis process is also inhibited, as well as ketogen. Okay, keto acids. Guys, this area is very, very important. Why? Because especially if you want to understand the next 15 minutes of the lecture, you need to know this. So not what exactly insulin is doing. Insulin inhibits glycogenolysis, gluconeogenesis, lipolysis, and ketogenesis. So insulin inhibits the ketone body production in the body. Ketone bodies are high energy rich substances. We will discuss about it. What exactly are these ketone bodies and how they are going to be helpful. Now, what normally insulin is doing? Inhibiting the ketogenesis. Insulin act on the liver, so ketone body production is inhibited. Now, why I am saying this? Because see, if I am the person who is suffering with diabetes mellitus, especially type 1 diabetes mellitus, if I am the person who is suffering with the type 1 diabetes mellitus, what happens? There is no insulin. What happens in my liver? Ketone bodies are produced, causing diabetic ketoacidosis, sir. Diabetic ketoacidosis. Okay. Now, after this, let's talk about diabetic ketoacidosis. Okay. If you have any doubts, you can put it in the chat box. For the next 15 minutes, please be very attentive. The concept which we are going to discuss is called as the diabetic ketoacidosis. Now, diabetic ketoacidosis. Okay. Now, first of all, why we are calling it as a diabetic? Diabetic means the patient here, it's mainly seen in DKA. Now, this diabetic ketoacidosis is mainly seen in type 1 diabetes mellitus. It's mainly seen in type 1 diabetes mellitus. Okay. Now, what is the main problem in type 1 diabetes mellitus? We all know. In type 1 diabetes mellitus, sir, there is insulinopenia. What does it mean by, sir? The beta cells. Okay, the beta cells are destroyed. It's an autoimmune disorder. Type 1 diabetes mellitus is a autoimmune disorder where the beta cells of pancreas are damaged so that there is no insulin. There is no insulin. Now, let's go one by one. If there is insulin deficiency, yes, insulin deficiency is there. Now, what happens if there is insulin deficiency? Now, tissues cannot utilize glucose. Okay, the tissues cannot utilize glucose. Now, what happens? Whenever the tissues cannot utilize the glucose, there is more glucose in the blood. Okay, in the blood, there is more and more glucose present. Okay, no doubt. Now, more glucose is there in the blood, but tissues cannot utilize the glucose because there is no insulin. Now, what your body will think? Your body will think in a way that there is no glucose. There is no glucose. Your body doesn't know that, okay, there is no insulin. That is the reason why there is no that is the reason why the tissues cannot utilize the glucose. Your body, what your body will think is, oh my god, this person is not eating. Simply it will think like this, the person is not eating. That is the reason why there is no glucose. So what your body will do now? Your body will do counter regulation. Okay, your body will produce counter regulatory hormones. Okay, COUNTR, counter regulatory hormones. Counter regulatory hormones are produced. Now, what are these counter regulatory hormones? The counter regulatory hormones are glucagon, epinephrine, okay, epinephrine, glucagon, epinephrine, cortisol, okay, and growth hormone. Growth hormone. Now, you just think logically and tell me, why these hormones are getting produced? Why unnecessarily these hormones are getting produced? Sir, the patient cannot utilize the glucose. Okay, we have seen the glucose is there in the blood, but the tissues cannot utilize the glucose. Now, what body will do? Body will think like, oh my god, the tissues are not getting the glucose. Your body will think like, there is no glucose in the blood. So, what your body will do is, it will help in the production of it. It produces the counter regulatory hormones. All the hormones which I have listed here, all these hormones, they all, now what they will do? All these hormones further increase the blood glucose levels. Okay, they are further increasing the blood glucose levels. Glucagon increase the blood glucose levels. Epinephrine increase the blood glucose levels. Cortisol, growth hormone, all of them further increase the blood glucose levels. Already there is more glucose in your blood. Now there is further increase in your blood glucose levels. Now what happens? This is all happening in a patient who is type 1 diabetes, who is suffering with type 1 diabetes mellitus. Now his blood levels of glucose is so much. Now all this glucose, where it is going? It is going to kidneys. Okay, it is going to kidneys, into the nephrons. For what? For playing? No, for filtration. Okay, now what will happen? Now there is so much amount of glucose is there in the blood. Now do you think all this glucose is going to be reabsorbed? No, all this glucose will be filtered, no doubt. Glucose molecules are freely filtered, but there is so much amount of filtered load, so all this glucose cannot be reabsorbed. Now all this glucose, where it is going? This glucose is going into urine. Now we all know glucose is osmotically active substance. Glucose is osmotically active, which means wherever it goes, it will take the water along with itself. We know about the sodium, right? Sodium, wherever sodium goes, water follows. In the same way, wherever glucose goes, water follows. So now in this person who is suffering with the type 1 diabetes mellitus, there is lots and lots of glucose is going in his urine. Along with the glucose, lots of water will be moved osmotically. So this patient will have what? This patient, first of all, he is having glucoseuria. Glucoseuria. Urine, there is glucose. And also this patient now, he will have polyuria. Okay, now you will know, from now you will know, you have to say, now if someone comes to you and asks you why a diabetes patient is having excessive amount of urination. Excessive amount of urination is because he is losing lot of glucose in his urine. The glucose is dragging the water along with itself. So there is polyuria. So whenever he is having polyuria, he is losing lots and lots of fluids from the body. So this polyuria will cause what? Dehydration. Okay, so up till now there is not much problem. There is a dehydration. Okay, the person is getting dehydrated. Now whenever he is getting dehydrated, now this person will try to drink more and more water, which will cause polyuria. dipsia. Okay, now this patient is having first polyuria, and now that causes dehydration, and now later this patient is now suffering with polydipsia. Okay, let me write it clear here. Polydipsia means excessive drinking water, like polyuria and polydipsia, excessive thirst. Now up till here it's everything okay. Now comes the real problems. What is that? Normally I have explained to you, the insulin will inhibit a process called as a ketogenesis. Okay, till the time you have good amount of insulin levels every day to day, now there is no production of ketone bodies. Now this patient, the glucose is not getting entered into the tissues. The tissues are starving, they are not getting the glucose. Now what the patient's liver will do is, so now the patient, whatever the fats were there in his body, now those fats will undergo lipolysis. Now with lipolysis, the patient is going to have fatty acids are getting produced in his body. Now, what these fatty acids will do? They will go to liver, and in the liver, these fatty acids are getting converted into ketone bodies. The fatty acids are getting converted into ketone bodies. Okay. Now at the end of the day, what do we have, guys? Ketone bodies are there in the blood. Now, can you give me examples of ketone bodies? There are three important ketone bodies which are there from the biochemistry. The three important ketone bodies are acetone, beta hydroxy butyrate. Okay, beta hydroxy butyrate and acetoacetate. Okay, now in this patient's body, a new thing is happening. There is a production of ketone bodies. Why ketone bodies are getting produced? Normally, see, these ketone bodies are highly energy rich substances. Now these substances can go enter into the tissues, and these can be utilized as a source of energy. Okay, see, you can derive the ATP out of glucose. In the same way, you can also derive energy out of these ketone bodies. So your body is compensating. Okay, glucose is not going, so ketone bodies are getting synthesized. But see, now because of the presence of acetone in the blood, now this acetone will cause sweet breath. Now whenever you see a patient who is suffering with a DKA, diabetic ketoacidosis, the patients will be having very sweet breath. Now why we are calling it as a diabetic ketoacidosis? Why? Because first of all, the patient is diabetic. The first problem is diabetic, type 1 diabetes mellitus, no insulin. So that is the reason why DKA, K for ketones, are getting produced. And why that acidosis? So the ketone bodies, beta hydroxybutyrate, acetoacetate, acetone, all these are keto acids. So these acids will cause acidosis in the body, and the sweet breath is because of the acetone. Okay, now because of the acidosis, whatever is happening, okay, because of all these keto acids, there is acidosis. Now whenever there is acidosis, we know, see, there are three levels of regulation. First is buffer system. Second one is lungs. Lungs will also help to maintain your pH, and even kidneys. The third line of control is the kidneys. Now right now, see, what I am saying is, a person is suffering with acidosis. So automatically his lungs will ventilate more. Hyperventilation is going to be seen. Because of the acidosis, there is hyperventilation. You can ask me why there is a hyperventilation. So the concept is very simple. What exactly is hyperventilation? Deep breath, deep exhalation. Deep inhalation, deep exhalation. Whenever the person is doing hyperventilation, he is actually removing the puffing out carbon dioxide out. Okay, so he's puffing out the carbon dioxide out of the body. So whenever carbon dioxide is going out, normally in the body, what happens? Carbon dioxide will react with the water, helps in the production of H2CO3, and this H2CO3 will split into H plus ions and bicarbonate ions. Okay, H plus ions as well as bicarbonate ions. Now what is happening? You have removed the carbon dioxide from the body with hyperventilation. Whenever the person is hyperventilating, there is no carbon dioxide. Carbon dioxide is getting out of the body. So the proton production is now going to come down. Already the patient is suffering with acidosis, right? So immediately lungs will start to hyperventilate. This type of breathing is called as the hyperventilation. Now these patients with the diabetic ketoacidosis, whenever you see a patient, whenever you are doing your clinicals, whenever you encounter a patient who is suffering with a diabetic ketoacidosis, he will be breathing like this, hyperventilating. Why hyperventilation? To take out the carbon dioxide from the body. So that proton production in the body will go down. So this type of breathing is called as, anyone knows what is the name of this type of breathing? Can anyone knows what is the type of this breathing called as? Kusumals. Okay, Kusumals breathing. Okay, Kusumals breathing. Okay, so Kusumals breathing is seen. So these are the important points which you need to know regarding diabetic ketoacidosis. Now, what is the treatment for diabetic ketoacidosis? Very simple, sir. All this diabetic ketoacidosis is because of deficiency of insulin. Deficiency of insulin. What do you have to do? So the drug of choice to treat diabetic ketoacidosis is give insulin. Okay, give insulin. So everything is going to be treated. Everything is going to be treated. So we have also discussed the important point about diabetic ketoacidosis. Now after this, let's start about the new hormone which is called as a cortisol. Okay guys, let's take a break of just 5 minutes. Now after the break, let's do cortisol and let's wrap up this session. Okay, now in the cortisol abnormalities, we'll mainly discuss about the Cushing syndrome. Cortisol, important functions of cortisol, and what exactly is Cushing syndrome, what are the clinical features of Cushing syndrome, we'll discuss in a 5 minutes. Hello, welcome back guys. Now let's discuss about the next important hormone which is cortisol. Now, before understanding about the cortisol, before discussing about the cortisol and its functions, now let's first discuss about the some important points about the adrenal gland. Okay, adrenal gland. Now, we all know how many parts are there in the adrenal gland. Now, every student knows that adrenal gland is mainly made up of two parts. The outermost part is the cortex and innermost part is the medulla. Now, important MCQ which I want you to know is, so the cortex is derived from, okay, embryology. The cortex is derived from intermediate mesoderm. Okay, the cortex is developed from intermediate mesoderm, and the adrenal medulla is actually derived from the neural crest cell. Neural crest cells. Okay, so neural crest cell in origin. In your anatomy, especially, these questions are continuously being asked, especially from the anatomy point of view. Which of the following structures in your body are derived out of neural crest cells? Okay, I'm just trying to integrate here the anatomy link. Okay, so what are the structures which are derived of the neural crest cells? Guys, there is a mnemonic. The mnemonic is MPSC goal. Okay, MPSC goal. Now we all have here in India, there is an exam called as UPSC exam. Okay, UPSC exam, just like that, remember it like MPSC goal. Cracking that exam is your goal, MPSC goal. Now what exactly is ESM, sir? Melanocytes. Okay, the melanocytes are derived out of the neural crest cells. So the neural crest cells which are formed during the development of the central nervous system, they have migrated. There are certain cells called as the neural crest cells. These neural crest cells, they have migrated to different places in your body, and they form different structures. Now, one such structure is melanocytes, and P for parafollicular C cells. The parafollicular C cells which are producing the calcitonin, and S for Schwann cells. Okay, CHWA and Schwann cells. The Schwann cells are also derived out of the neural crest cells. Now, what exactly are the Schwann cells? Just don't forget, guys, Schwann cells are the myelinating cells. Myelinating cells in peripheral nervous system. Okay, the peripheral nerves, all the spinal nerves, all the cranial nerves, 12 pairs of cranial nerves and 31 pairs of spinal nerves, all of them, they are myelinated or not? They are myelinated. Who gives the myelin coating? The myelin coating is given by Schwann cells. Okay, in the central nervous system, the neurons are myelinated. Who gave that myelination in central nervous system? Oligodendrocytes. Okay, but here what I am saying is the Schwann cells, the myelinating cells, are also derived out of the neural crest cells. And C for chromaffin cells, the chromaffin cells which are present in the ganglia, sympathetic and parasympathetic ganglia. Now the chromaffin cells which are present in the ganglia are derived out of neural crest cells. And C for, again one more C is there, conotruncal septum in heart. Okay, the conotruncal septum is also derived out of neural crest cells. And G for all the ganglia. Okay, all the ganglia, sympathetic ganglia, parasympathetic ganglia, and the cells in the ganglia called as the chromaffin cells, everything is derived out of neural crest cells. And O for odontoblast. Okay, odontoblast. And A for adrenal medulla. Okay, odontoblast, adrenal medulla, and L for leptomeninges. Okay, leptomeninges. What exactly are the leptomeninges? Pia mater and arachnoid, not the dura. So what and all I have shown you here, the MPSC goal, these are the things which are, these are the organs in your body which are derived out of neural crest cells. Here, what is the important point which I want you to know is the adrenal medulla. Okay, this adrenal medulla is derived out of neural crest cells, but the adrenal cortex is made up of intermediate mesoderm. After discussing, now let's start the important hormone which is cortisol. Now cortisol is coming from adrenal gland, no doubt, coming from adrenal gland. From where? Adrenal cortex or adrenal medulla? Definitely from adrenal cortex. Now, adrenal cortex is further divided into many regions: zona glomerulosa, zona fasciculata, zona reticularis. Three regions are there: glomerulosa, fasciculata, reticularis. GFR, glomerulosa, fasciculata, reticularis. Three regions are there. From where cortisol is coming? See, whenever ACTH, adrenocorticotropic hormone. Normally, adrenocorticotropic hormone will come from the anterior pituitary. Now, this adrenocorticotropic hormone, it will come and act on the adrenal cortex. Now, from the adrenal cortex, especially from zona fasciculata releases cortisol. Cortisol is what kind of hormone? It's a glucocorticoid. So the name itself is there. It is associated with glucose metabolism. So remember, from now, cortisol, it increases the blood glucose levels. Whenever you see cortisol, it increases your blood glucose levels. And cortisol is also called as stress hormone. Stress hormone. Now, why it is increasing the blood glucose levels? To encounter the stress. It prepares your body to encounter the stress. Whenever you have cortisol, cortisol increases your blood glucose levels, and this blood glucose levels, this glucose will help to fight against the stress. Okay. Now, first of all, this cortisol, is it a catabolic hormone or anabolic hormone? Cortisol, it's a absolutely catabolic hormone. Catabolic hormone. Okay, it's a catabolic hormone. What does I mean by catabolic hormone? See what it is exactly doing. Let me write it down here. Cortisol. Now, cortisol, it will act on proteins. Now, what it will do to the proteins? Cortisol, what it will do to the carbohydrates, and what the cortisol is going to do to the lipids. Now, we have to see. I have said you already, it's a catabolic hormone. So, proteolysis is going to happen. Okay, so proteolysis, proteins are going to broken down. Even what happened to carbohydrates? Carbohydrates are going to broke down and increases your blood glucose levels. Blood glucose levels are elevated. Okay, and what happened to lipids? Lipids are also going to broke down. That is lipolysis. Lipolysis is going to happen. Whenever lipids are getting broken down, the free fatty acid levels in the blood are going to be elevated. Free fatty acid levels are elevated. Okay, now let's see how the patients with Cushing syndrome look like. Now, just by looking at it, you will think that cortisol, it's a catabolic hormone. So, if it's a catabolic hormone, usually the students will think like this. Yes, it's a catabolic hormone. So, it is broken down everything. Now, the patient is going to become lean or not? Or the patient is going to be obese? Sir, actually, the patients with Cushing syndrome, they will have centripetal obesity. Okay, especially see, they will be having a big belly like this. Okay, big belly with big buttocks, and they are going to have very thin proximal, like proximal extremities as well as the distal limbs. Okay, distal extremities. The extremities are going to be very thin. The extremities are going to be very thin. Why? Because proteolysis. All the muscles, whatever were there, these muscles are getting destroyed. These muscles are getting destroyed because of the cortisol. Okay. So what happens to the extremities? They become very much thin. But why there is centripetal obesity? Actually, they are going to have a very big belly. They are going to be obese, especially in the central axis of the body. Why there is centripetal obesity? Why there is centripetal obesity? If you ask me, the centripetal obesity is because of something, a mechanism which I am going to teach you now. So, in Cushing syndrome, there is excessive cortisol. Now, what this cortisol will do? Cortisol increases the blood glucose levels. Now, whenever there is excessive amount of blood glucose, see, this excessive amount of blood glucose will release high levels of insulin. Okay, insulin levels are also going to be elevated. Cortisol increases the insulin levels by increasing the blood glucose levels. Now, what this insulin will do? Now, it will stimulate the adipocytes. Stimulates adipocytes. Okay, now which adipocytes, especially the adipocytes which are present in the belly region, especially present in the buttocks region. Now, adipocytes are getting stimulated, they will undergo hyperplasia and hypertrophy. Okay, there is hyperplasia of adipocytes as well as the hypertrophy of adipocytes. Now, because of the high glucose levels, there is excessive insulin. This insulin will stimulate. The insulin targets the adipocytes, especially in the center of the body, makes the adipocyte hyperplasia. Adipocytes are going to become big in size. So, these persons are having very thin extremities. But whenever you look at the center of the body is more obese. So this is called as a centripetal obesity. Okay, now let's see what are the actions of cortisol one by one. Now if you understand the actions of cortisol, the Cushing syndrome is dead easy for you, dead easy. Okay, now let's see actions of cortisol. Now what cortisol will do to bones? What happens whenever cortisol acts on the bone? Cortisol activates osteoclasts. Okay, it's the clast important. Osteoclasts are activated. Whenever osteoclasts are activated, what happens? Bone resorption. Okay, this is also like metabolic hormone, right? It's destroying everything. So bones are under risk. Normally cortisol will cause bone resorption by activating the osteoclast. And the cortisol, okay, the glucocorticoid is actually steroid. It's the adrenal hormone, right? All the adrenal hormones are steroids. They are made out of cholesterol. The aldosterone, cortisol, sex corticoids, everything which are coming out of adrenal gland, they are sterols. They are derived out of cholesterol, steroid hormones. Now we all know steroids are anti-inflammatory or not? Yes, sir. Even our cortisol is anti-inflammatory. Okay, now why it is acting as an anti-inflammatory? This is the first function, this is the second function. Why it is acting as anti-inflammatory? Because cortisol, it decreases the inflammatory mediators like histamine. Histamine levels are going to go down, prostaglandin levels are going to go down, and interleukin 2, especially interleukin 2 levels will go down, decreases the activity of phospholipase A2. So very simple, whenever there is no phospholipase A2, there is no arachidonic acid. Whenever there is no arachidonic acid, there is no cyclooxygenase pathway. Whenever there is no cyclooxygenase pathway, there is no prostaglandins. So what I am saying is, this cortisol, it will cause deficiency, it will inhibit the synthesis of inflammatory mediators. Whenever there is no inflammatory mediators, there is no inflammation. Okay, so cortisol is acting as the inflammatory mediator. Now, what this cortisol will do to the blood vessels? Cortisol will act on the blood vessels, maintains the tone of the blood vessels. Actually, cortisol helps in maintaining the tone of the blood vessels. So normally cortisol increases the blood pressure. Cortisol is a very, very important hormone in maintaining the blood pressure. Okay, you know it. Now cortisol action on GIT. What it will do? Increases the acid production. Okay, cortisol increases the acid production. Now, why I am saying all this is because, see, whenever we discuss about the Cushing syndrome, there we will say, sir, in Cushing syndrome, what happens? There is excessive amount of cortisol. Whenever there is excessive amount of cortisol, see, if I am the patient who is suffering with Cushing syndrome, lot of cortisol, sir. Now, lot of cortisol will act on the GIT. More acid is going to produce in my stomach. That will cause peptic ulcer disease. So, like that, we will correlate. Just now, let's see what are the normal actions of cortisol, and in hypercortisolism, what kind of clinical features will be seen? Okay, first we'll discuss normal functions. Cortisol acts on the GIT, helps in production of more acid. Now, cortisol action on the reproductive system. Normally, cortisol is a stress hormone. It is going to be produced in stress conditions. In stress conditions, do you want reproductive activity to happen in your body? No. So, what happened to your reproductive system? All the reproductive hormones, especially the GnRH, the main important hormone, GnRH, the gonadotropin releasing hormone levels, GnRH levels goes down. Whenever GnRH level goes down, automatically FSH will go down, LH will go down, estrogens will go down, progesterones will go down, everything is going to be down regulated. Okay, so cortisol decreases the reproductive activity. Cortisol, what it will do to your blood cells? That is WBC. Here, one important point is, every student knows that the steroids are immunosuppressant drugs. They decreases the activity of the immune system. WBC are a part of the immune system. So what is happening to the WBCs? Cortisol, it decreases certain WBCs and increases certain WBCs. See, cortisol increases the neutrophil count. Okay, increases the neutrophil count, but the same cortisol will decreases other WBCs, especially eosinophils. Okay, so eosinophil count is going to be greatly decreased, neutrophil count is increased. This is very, very important. Neutrophil count is elevated. Okay, eosinophil count is going to be decreased. Now, after discussing all this, now let's discuss about the pathology. Okay, pathological link. What is the pathological link? The pathological link is Cushing syndrome. Cushing syndrome. Now, what exactly happens in the Cushing syndrome? There is excessive amount of cortisol. Okay, there is lots of cortisol in the body. What is the most common cause of Cushing syndrome? The most common cause of Cushing syndrome is iatrogenic. Iatrogenic. What exactly I mean by iatrogenic? Normally, the doctor is prescribing. Okay, see, for example, imagine that I am a patient with rheumatoid arthritis. I am a patient with rheumatoid arthritis. So I am having lots and lots of pains. So to decrease these pains, the doctor will definitely recommend steroids to me. Now, for example, if doctor prescribe more steroids, more dose of steroids, so I am taking more doses of steroids. Now, this steroid is nothing but a corticosteroid, glucocorticoid. So what happened? It causes Cushing syndrome. It causes Cushing syndrome. What is the most common cause of Cushing syndrome? Iatrogenic in the nature. It is because of a doctor. Okay, doctor prescribed more doses of steroids. So especially the glucocorticoids. They are decreasing the pain, no doubt, but they are causing unnecessary side effects. And that side effect is nothing but our Cushing syndrome. Okay. Now, let's write down the clinical features one by one. Now, what are the clinical features of Cushing syndrome? Guys, very simple. These patients are going to have hypertension or hypotension. Just tell me. I have already explained to you. Cortisol acts on the blood vessels, increases the tone inside the blood vessels, increases the tone of the muscles around the blood vessels. So, normally increases the BP. So, cortisol increases the BP. So, in Cushing syndrome, what happens? The patient is going to suffer with hypertension. Okay, the patient is going to suffer with hypertension. Now, what happened to his muscles? What happened to his muscles? Muscles are undergoing destruction. Cortisol causes proteolysis. So, there is muscle wasting. Okay, there is muscle wasting. And these patients are having centripetal obesity or not? Yes, these patients are having centripetal obesity. Okay, centripetal obesity, especially because of the hypertrophy of the adipocytes. Hypertrophy of the adipocytes causes centripetal obesity, and all the fat is going to deposit, especially in the center of the body. Because of the adipocyte hypertrophy, especially these fats are getting deposited in the center of the body, in the belly, so that he's having a very big belly, and the fat is going to deposit on the back of his thorax, which will cause buffalo hump. Buffalo hump. Okay, he's going to have a very big lump, which is nothing but a fat deposition. So it will cause buffalo hump. Even the fat is getting distributed in his face, that causes moon faces. Okay. So the patient's face is absolutely like a moon face, round face, centripetal obesity, buffalo hump is there, the muscles are getting wasted, he is having hypertension. The patient is having hypertension. Now, as his abdomen is increasing in size, centripetal obesity, what happens? You can see abdominal striae. Okay, abdominal striae. Abdominal striae, nothing but the stretch marks. Okay, so just a second, let me take a second and let me show you. See, this is how a patient with Cushing syndrome looks like. Okay, this is how the patient with Cushing syndrome looks like. See, he is having centripetal obesity. You can clearly see he is having moon faces. Centripetal obesity is seen, and you can also appreciate these stretch marks here. Now, why does these stretch marks are present? Now, these stretch marks are because he is having abdominal distension. That is the one reason. And not only that, see, I have explained to you that cortisol, it will destroy proteins or not. Cortisol destroys the proteins. Now, cortisol, it's acting on the proteins in the skin. Which proteins? Collagen. Collagen is a very important protein which is present in the skin. So, cortisol is damaging the collagen. So, what happens is the skin is becoming thin, very much thin. So, you can have this striae. So, abdominal striae, the stretch marks are because of the abdominal distension, one reason, and also because of the loss of collagen. And seventh important point is, so these patients will have easy, this is the very keyword, very important keyword, easy bruisability. Okay, these patients are having easy bruisability or easy bruising. Okay, These patients are having easy bruising, which means what? So whenever there is a small, like, small trauma to his body, he's going to bleed in that particular area. He's going to bleed. Now why he's bleeding? Why? Because again, same thing. Even the blood vessels are made up of collagen. Now collagen is getting broken down. Collagen is getting, like, damaged. So the blood vessels are getting weaker. So what he's having is easy bruising. So easy bruising, don't forget that word, very, very important. Apart from that, these patients are going to suffer with immunosuppression. Okay, immunosuppression is going to be seen. Why? Because the entire steroids, all the steroids are immunosuppressants. They will reduce the activity, they will decrease the activity of the blood cells, especially the WBCs. And these patients are having hyperglycemia or hypoglycemia. These patients will have hyperglycemia. These patients are having hyperglycemia. What does I mean by hyperglycemia, sir? Simple. Cortisol, stress hormone. Cortisol increases the glucose levels. So more glucose levels are going to be there in the blood, that's causing hyperglycemia. And other features. What are they? Especially if a female is suffering with Cushing syndrome, she will have features like amenorrhea. She will have amenorrhea. Why? Because cortisol, stress hormone, inhibits the reproductive axis. GnRH levels goes down. Whenever there is no GnRH, there is no FSH, there is no LH. So entire reproductive axis is inhibited. So now she is suffering with amenorrhea. And other features like these patients will suffer with peptic ulcer disease. Why? Because cortisol increases the gastric acid secretion. So more gastric acid means peptic ulcers can form. Simple peptic ulcer disease. And what else? The 12th clinical feature is osteoporosis. Osteoporosis is going to be there. Why there is osteoporosis? Cortisol activate osteoclast. Osteoclasts are causing bone resorption. If there is too much bone resorption, that causes osteoporosis. Now, clinical feature number 13, these patients will have hirsutism. Hirsutism. What exactly is hirsutism? It's the facial hair. Okay, especially in females. Okay, these females, they will develop facial hair. Okay, now let me show you in an image. This female is having, you can clearly see this female is having moon faces. Okay, moon faces. Along with that, now she is having this abnormal facial hair. Now why there is this abnormal facial hair? See, in high quantities the cortisol will act like sex steroids. See, cortisol is a glucocorticoid, everyone knows. Okay, see, cortisol, let me show you. See, this is the house. This is the house. What is the house? Adrenal gland. Adrenal gland is the house. From this house, three brothers are coming out. Okay, they are just like brothers. Aldosterone, cortisol, and sex steroids. Aldosterone is an example of mineralocorticoid. Cortisol is an example of glucocorticoid. And from here, dihydroepiandrosterone will come. Testosterone will come. Is an example of sex corticoid. See, all these are like a brother from one home. So, cortisol will act like mineralocorticoids like aldosterone. True. Cortisol will act like aldosterone sometimes in high quantities. True. Aldosterone will act like cortisol. Cortisol will act like sex steroids. True. No doubt. So right now what is happening is the cortisol in excessive quantities, it is now acting like sex steroids. It's now acting like sex steroids. Now we all know the sex steroids are the ones, especially the male sex hormones, androgens are the ones which are responsible for hirsutism, facial hair. Okay, now these females, they will have facial hair. Now the fourth important clinical feature which you need to know, very, very important keyword. This is the keyword, guys. Now the fourth important symptom is hyperpigmentation. Hyperpigmentation. Now whenever you look at the patient who is suffering with hypercortisolism, Cushing syndrome, whenever you just ask them to show their palms, now you can see the palms are very much dark. Okay, even their skin will look a dark tone will be there. Okay, now why there is this hyperpigmentation? Very, very important, because see, this hyperpigmentation especially seen whenever the Cushing syndrome is because of a pituitary gland tumor. See, right now what I am saying is there is a pituitary tumor. Now this pituitary tumor is producing excessive amount of ACTH. Now what this ACTH will do? This ACTH will come to the pituitary, will come to the adrenal gland. It is acting on the zona fasciculata. So more cortisol is being released. So more ACTH, more cortisol, causing Cushing syndrome. Okay, Cushing syndrome. So everyone knows this. But what I am saying is here, why there is hyperpigmentation? This hyperpigmentation is because this excessive amount of ACTH. Do you know what it will do? This excessive amount of ACTH will act on melanotropin receptors. Okay, it will act on this. ACTH can also act on it. It's having a capability to stimulate the melanotropin receptors. So this melanotropin receptor stimulation will help in production of more melanin that will cause hyperpigmentation. So a patient, remember these are the keywords. A patient who is suffering with hypercortisolism or Cushing syndrome, they will have centripetal obesity. Muscle loss will be there. Okay, muscle loss will be there. Centripetal obesity, moon faces, buffalo hump. Along with that, these patients will have hyperpigmentation with easy bruisability. Now, these patients, like while looking at these patients will look like, see, like this. Okay, they are having centripetal obesity and their extremities looks like this. This is called as lemon. Okay, in the center of the body, it's looking like a lemon. Okay, it's looking like a lemon. Lemon on sticks. Lemon is standing on the sticks. These are the sticks, matchsticks. Okay, so lemon on stick appearance. So lemon on stick appearance is seen in which disease? The lemon on stick appearance is seen in Cushing syndrome because of the centripetal obesity with loss of muscles from the extremities. With this, we have also discussed about a very important hormone, that is cortisol. So we are done with the insulin, all the important points, and we have also done with the cortisol. And we have also seen the important functions of the thyroid hormone, abnormalities of the thyroid hormone, and anti-thyroid drugs. Okay guys, we are done with the class. Okay, if you have any doubts, you can all the time post it in the group, and the entire the PDF, today's PDF and yesterday's PDF, we will post it in the Telegram. Okay, in the Telegram group. Hope the class is helpful. See you with our next classes. Okay, in the next classes we will take up the new physiology topic and we will discuss. Okay guys, thank you. Bye bye.